Hello guys, welcome to Pajon Imaging Hub. In today radiographers and other health professionals education series, we look at diagnosis of tuberculosis using chest X-ray. Please don't forget to like, share and subscribe to this channel so that you'll be notified when new video is released. So we'll look at the diagnosis of TB using chest X-ray based on this outline. What is TB, type of TB, features of primary TB, features of secondary TB, miliary TB, ranking complex, and chest images of TB. Look at some images to see how TB appears in chest X-ray. Tuberculosis is infection caused by Mycobacterium tuberculosis. It mainly affects the respiratory tract. That is what we regarded as the pulmonary tuberculosis. But it can affect other parts of the body, including the spine. Now, tuberculosis we want to focus in this lecture is the pulmonary tuberculosis. Tuberculosis can be grouped into primary and secondary tuberculosis. Primary tuberculosis is the tuberculosis that occur in people who have not been exposed or previously infected with tuberculosis. No history of tuberculosis infection exposure in this category. Post-primary tuberculosis is the tuberculosis that develops in individuals who have previously been infected with TB. Now, this could result from reactivation of dormant Mycobacterium tuberculosis bacteria or from reinfection with a new strain. So let's look at the features of primary tuberculosis. Well, one of the feature is normal chest. When a patient comes and being queried for to rule out TB, absence of any other features of TB, just by seeing only normal chest is not enough to say that the patient doesn't have tuberculosis. The gold standard for TB screening is sputum test, not chest X-ray. Chest X-ray may be normal in as many as 15% of patients with primary TB. So seeing a normal chest X-ray is not enough to say that the patient does not have tuberculosis. And the second one is lymphadenopathy. Hilar lymphadenopathy is hallmark radiological finding of primary TB. Lymphadenopathy without a parenchymal opacity may occur as the only manifestation of primary TB. There could be presence of calcified lymph nodes. So you can see a chest X-ray where the only thing you see is lymphadenopathy and without no other signs, and that could be a sign of TB. Consolidation is the next feature. Consolidation in primary TB can occur in any segment or lobe, but it has predilection for the lower lobes, the middle lobes, lingular, and the anterior segment of the upper lobes. Cavitation within parenchymal opacity is uncommon in primary TB. As the host immune response continues, healing begins. Necrosis occurs centrally within the lung parenchymal opacity, decreasing its size. The lung opacity tends to become rounded with healing, and it continues to shrink until a small nodule remains. Subsequently, the nodule may become calcified or ossified, resulting in a calcified granuloma. We need to understand this point. That is how the immune system fights tuberculosis. A granuloma may calcify, but this does not necessarily reflect an absence of bacilli, that is the bacteria that causes tuberculosis. The organism may remain quiescent within this nodule, serving as a possible source for reactivation of disease. So we've seen the link between the primary TB and possible reactivation of TB, which will now be regarded as post-primary TB. And the next feature is tuberculoma. But what is tuberculoma? I would like to state that granuloma is a general term for a cluster of immune cells, primarily macrophages and lymphocytes, that form when the body attempts to wall off and contain an irritant or foreign substance that it cannot eliminate. That is granuloma. You see, I have been using granuloma, but tuberculoma is a specific type of granuloma caused by tuberculosis infection, characterized by caseous necrosis and a distinct appearance on imaging. So tuberculoma are rounded discrete nodules that are known to harbor the bacteria, that is the bacilli. So those nodules or granuloma you see, if the case in question is tuberculosis, then it is called tuberculoma. Granuloma can be found in some other infectious diseases. It is caused by the reaction of the immune system against the bacteria, just as we have seen. And the next feature is atelectasis. Atelectasis may occur in primary pulmonary TB, often as a consequence of tuberculous airway involvement. So is the when we're looking at the difference between primary and post-primary TB, you will discover that in primary TB there could be volume loss, but that is not due to fibrosis. It may be due to blockage of the airway. Then the next feature of primary TB is pleural effusion. There could be pleural effusion. Pleural effusion develop if the infection remains untreated. So let's look at features of secondary tuberculosis. The first one is history of TB exposure or infection. There must be a history of TB exposure or infection, or a previous film to state that this patient have had TB before we can make diagnosis of post-primary TB. And we have to know that inactive disease cannot be established without prior radiographs, regardless of the pattern you see in the radiograph. Because inactive disease that probably left maybe granuloma, it could be from any other disease. And as long as inactive, you cannot detect the type of disease it is, unless you have a supporting evidence of a prior radiograph that shows what transpires in the past. Now, the other feature of post-primary TB is fibrocavitary disease features. You will see fibrosis, sign of fibrosis, and cavity. It is in post-primary TB that cavity is commonly seen. In post-primary TB, the earliest radiological sign is small nodule and branching central lobular lesions that increase in size and coalesce to form ill-defined patchy consolidation. The other sign also is tuberculoma. You will see tuberculoma. I've already explained extensively what is tuberculoma. It's also a feature that you see in post-primary TB. Now we'll look at the difference between primary and post-primary TB. The first difference is history of TB. Yeah, that is why we normally tell patients to come with a previous films so that we can check whether the patient have had TB in the past to help in making the diagnosis at the present. If there is primary, if there is a history, you now know it's post-primary. But if there is never been sign or exposure to TB, then it has to be primary TB. Then lymphadenopathy is found in primary TB. Is rarely seen, if at all, in post-primary TB. Then fibrosis is common sign of post-primary TB. And wherever there is fibrosis, there is tendency of volume loss. The next one is miliary tuberculosis. There are two things to note about miliary tuberculosis. One, it is a hematogenous spread of TB, and two is you will see a multiple 1 to 2 millimeter multiple nodules in both lungs. So, pulmonary miliary tuberculosis is a consequence of hematogenous spread of organisms to the pulmonary parenchyma. Radiographically, miliary spread can be recognized by circumscribed nodules less than 1 to 2 in diameter located diffusely throughout both lungs. These are features of miliary TB. There is a radiograph I have that I will show in a moment that shows patterns of miliary tuberculosis. Then there is this concept of we call a Ranke complex. Ranke complex is a radiographic appearance indicating a healed primary tuberculosis infection. It consists of a calcified granuloma in the lung and ipsilateral calcified mediastinal or hilar lymph nodes. It represents a later manifestation of the Gond complex, which is the initial combination of a lung granuloma and affected lymph node. That is what we call Ranke complex. I have an image that clearly show what the pattern look like in chest X-ray. We'll see that in a moment. So let's look at chest images of TB. Of course, this is a normal chest X-ray. There is nothing abnormal in this chest X-ray. The lung fields are clear. The spines, the ribs are clear. There is no opacity. There is no abnormal opacity you will see in this chest X-ray. It is a normal X-ray. So this could also be a sign, as I've stated before, of TB. So with this kind of X-ray, you cannot say that the patient does not have TB. Chest images of TB, like this one, what we have here is hilar adenopathy. See how big it is? It is enlarged. So that is a sign of primary TB. See the mediastinal hilar adenopathy. See this place? There's things there. Lymph nodes enlargement. There's this one. There's this one. This hilar. This is a case of TB. So you can see signs. These are consolidation. You can see the whole diffuse consolidation in the lungs. See all these signs are consolidation. So this is a case of primary TB. There is no appreciable volume loss. There is no appreciable volume loss. We can see the horizontal fissure here. There is no volume loss. So this is a case of primary TB. Then you see this other case, see consolidation in this left upper lobe. See? Then there is volume loss. Then you see this uniform density around the pleural area. This is a pleural opacity or fibrosis. So there is a remarkable volume loss. You see the horizontal fissure is being pulled up. And you see this one also. You see the same sign here. The horizontal fissure is being pulled up. So there is a remarkable, you see consolidation. See consolidation. There's a remarkable volume loss. Then this is a feature of miliary TB. If you look closely, you will see small nodules, very tiny nodules, small nodules. Because of their confluence or their many number, So the chest X-ray now appear hazy. Look closely, you will be able to make out the tiny nodules. Tiny nodules that you can see diffusely in the two lungs. You can see the tiny nodules. There are ones that the nodules will be more distinct, but if you can detect this level, then that one will be easier for you to detect. Then this is a case of that what we stated earlier, the Ranke complex. We can see this is a calcified lymph node. Then if you look closely, we'll see calcified granuloma. See this one? You see this one? That is calcified granuloma. So the combination is what gives us the Ranke complex. So this is a good radiograph that indicates how Ranke complex looks like. This is a calcified granuloma. This is calcified granuloma. This one is calcified lymph node. Thank you. Like, share, and subscribe to this channel so you'll be updated when new video is released. Bye for now.